Thank you so much for the kind introduction. This saves me quite some time, so thank you very much for that. So let's jump right in for the morning session. We're going to be talking about the sepsis-associated liver dysfunction and what's new. So we're going to be going over why the liver matters in critical care, what makes sepsis-associated liver dysfunction so dangerous, what do we know about approaching sepsis-associated liver disease in the ICU? What works and what might work? And what can we do differently for our patients starting tomorrow? Now, the reason why this topic is of interest to every kind of intensivist is because we are already aware that any kind of intervention and any kind of serious complication we are thinking about in the critical care have a reflection on the liver, from medications to organ failure and the shock state and inflammatory cascade. But what is sometimes missing from the conceptualization of critical illness is how the liver failure in return affects everything that we are doing to the patient and everything that is happening with the patient. So what do we know about sepsis-associated liver dysfunction? We know that this is a frequent encounter in the ICU. At least 1 out of every 10 critically ill patients will present with a certain degree of liver dysfunction. But up to half of every septic patient will present with some kind of liver dysfunction. And we know that in sepsis, this is a highly dangerous manifestation, with ICU mortality compared septic patients with liver dysfunction and septic patients without liver dysfunction, the difference is day and night. And the same can be also told when it comes to in-hospital mortality, where septic patients who developed or who had liver dysfunction are at a much higher risk of mortality in the hospital. We also know that clinically, the manifestation of liver dysfunction is a relevant predictor of outcomes. And from the MIMIC database that has more than 90 centers and tens of thousands of critically ill patients in it, we know that regardless of the severity of the critical illness, the existence of liver dysfunction is an independent predictor of mortality outcomes. You can see here that even when the patient cohorts are matched with baseline characteristics and disease processes, the manifestation of liver dysfunction is an independent predictor of mortality. But most importantly, what we know about sepsis-associated liver dysfunction is that it's actionable, which means we can do something about it, but also we should do something about it. So this paper, published in the World Journal of Gastroenterology, has conducted a literature review which is clearly showing the increasing interest in sepsis-associated liver dysfunction in critical illness literature. And a network of researchers who are working on this topic seems like there are 5 families of researchers who are communicating with each other, who are in a network, who are working with each other, and they're coming from different continents. What is really sad is that in Eastern Europe, we are not part of this network, despite the fact that in Eastern Europe, or Central Eastern Europe, sepsis-associated liver dysfunction is quite frequent. So we have a lot of work to do to catch up with our international colleagues. So we know that sepsis and liver dysfunction have a bidirectional relationship, which means we know that sepsis is predisposing people to liver dysfunction, but in return, we also know that liver dysfunction is predisposing patients to sepsis. And existing or developing liver dysfunction in critically ill patients will increase the risk of incidence of sepsis by 2.6%. And it will also increase the odds of mortality by 2.4%. And again, it is an independent predictor of mortality in septic critically ill patients. But how do these patients present in real life? There are 3 clinical phenotypes. The first is the hypoxic hepatitis, which means that there is a perfusion problem in the liver. This develops within 24 hours, and it's due to compromised perfusion. 1 in every 3 patients with hypoxic hepatitis will progress into septic cholestasis or sepsis-induced cholestasis. And this will take some days in the ICU before we can observe what is going on. And unfortunately, some of these patients will further progress into secondary sclerosing cholangitis, which is a late-stage liver failure with an extremely high mortality. So here is what our patients are going to look like. Hypoxic hepatitis patients will present with shock-like symptoms. There will be an unbelievable increase in the aminotransferase levels of more than 20 times the normal range. And we can diagnose our patients with hypoxic hepatitis only after we exclude the other causes of liver disease. Then in septic cholestasis, we're going to see in the labs a disproportionate hyperbilirubinemia, which means the bilirubin is dynamically increasing in an exaggerated manner that is not paralleled by other liver function enzymes. Novel research shows that presepsin, which is a promising biomarker for the development of sepsis, is incrementally elevated in septic cholestasis patients. So are pro-inflammatory cytokines like TNF and interleukins. And finally, when the patients are progressing into sclerosing cholangitis, we will observe a rapidly progressing multi-organ failure for which, to this day, transplantation is the only known curative treatment. There is one more extremely dangerous clinical presentation, which is acute on chronic liver failure. Both sepsis and acute on chronic liver failure on their own are representing a high margin of mortality in the ICU. But when they come together, the mortality rate increases to up to 70%. These people are very sick and they are in need of a lot of help. So how do we approach our patients? Of course, everybody knows, I think, from memory, SOFA-score. And in SOFA-score, we have this quick assessment of liver function looking at the bilirubin. And that will tell us how the patient's liver is doing. But what we are not always taking into consideration are the liver manifestations in the other domains, like hepatopulmonary syndrome, or hepatic synthetic failure in coagulation, or portal hypertension and its manifestations for the circulatory system, or hepatic encephalopathy, when we cannot wake our patients up, when we cannot orient our patients, and hepatorenal syndrome, when the kidneys are unable to compensate for the lack of liver function. So that's why colleagues have developed certain different approaches to quantifying the liver functions of a critically ill patient. One of them is the MELD score. And MELD score is quite, in my opinion, quite subjective, but it correlates quite well with mortality. But if it was working so well, I don't think we would need to actually refresh the MELD scoring system basically every year. So let's go to quantifying the liver dysfunction in the critical care, or how I learned to stop thinking and love the scores. We already know liver dysfunction is prevalent in our patients. We already know it dramatically worsens prognosis. But more importantly, we have more scores and tests than we can use in a 24-hour cycle. So given this, what can we do about the liver? In the previous 25 years, clinical research on liver have focused on detection, differentiation, prognostication, stratification, and validation of these patients. Meanwhile, interventional trials have focused on 2 domains, which should guide our clinical practice. Number 1 is the timely resolution of sepsis, antibiotic treatment, and hemodynamic management. And the second domain is the compensation for the loss of liver functions. So replacing the synthetic function of the liver and purifying the blood when the liver is unable to do it. So what have we been trying to do? In terms of hemodynamics, There is a landmark randomized controlled trial comparing terlipressin and noradrenaline in patients with cirrhosis and septic shock. You can see from the Kaplan-Meier curve on the right-hand side that terlipressin is significantly better than noradrenaline. Fantastic news, excellent. This was a 2016 paper. And then comes a 2025 paper, which is showing terlipressin and noradrenaline in acute on chronic liver failure. No, terlipressin is actually not better. In fact, it is significantly worse for these patients. The previous study had a mixed cohort, whereas this one has patients who have more progressed liver failure. We also tried targeting higher versus lower mean arterial blood pressures to address the decompensated perfusion. Higher MAP targets were also not effective. So where do we stand with hemodynamic management for liver disease patients? We also have investigated some pharmacological and immune modulation therapies, like low-dose hydrocortisone. There's no mortality benefit. We failed to show any mortality benefit when we tried to address the dysregulated immune response with steroids. But when we try to compensate for the blood purification function of the liver by giving antioxidant properties of omega-3 fatty acid lipid emulsions, we saw that there is a strong signal that shows addressing the pro-inflammatory state in septic patients might be working. Then we also investigated some novel molecules which could help us with regulate the immune response, like interleukin-1 receptor blockades. And it seems that immune modulation for these patients might be of critical importance. I also have to mention our study with Jod, where we were looking at the hemoadsorption therapy for blood purification in seriously injured liver patients. And what we have found was, of course, from limited evidence, unfortunately, but still there was a significant reduction in the bilirubin levels of these patients. We also show that before and after treatment with hemoadsorption therapy, the vasopressor need of our patients have significantly decreased. And let's take a look at antibiotic therapy. This landmark study comparing an early, aggressive, broad-spectrum antibiotic strategy for patients presenting with sepsis and liver dysfunction improved survival in these patients significantly. And this result is partially replicated in randomized controlled trials on prophylactic antibiotics for patients in order to prevent the development of sepsis. However, a more recent network meta-analysis that was conducted by the Cochrane collaboration themselves, comparing 12 RCTs, more than 1,000 patients, and many strategies, showed no clear superiority in benefit for any strategy. So there's very high uncertainty and low level of evidence as to what is the best antibiotic strategy for these patients. So in summary, where we stand is in hemodynamics, there is no magic bullet. There is no magic agent. Organ perfusion is still the golden rule. And halting the dysregulated or exaggerated immune response is remaining a key aspect. And finally, although there is much to be clarified, prompt and accurate antibiotic therapy remains highly important. But what about the future? With developing technologies, the research methodology is also changing. And nowadays, the hottest topic in liver and sepsis is the gut-liver axis in sepsis, which draws our attention to sepsis-associated dysbiosis and the translocation of intestinal PAMP and DAMPs to the liver and via liver to the systemic circulation. Oxidative stress, hyperactivation of inflammatory cascades, and microbiota inflammasome crosstalk are all novel therapeutic targets. So we know the risks, we know the consequences, we have to act fast. So ask not what your liver can do for you, ask what you can do for your liver. JFK probably said this at one point. So thank you very much for your kind attention.